ثم أما بعد. السلام عليكم ورحمة الله وبركاته. Ladies and gentlemen, consultants, doctors, university professors, and my colleagues, resident and fellow. We are pleased to open the first board review course in Diagnostic Hematology. We will start with the recitation from a Holy Quran by Dr. Ahmed Al-Harbi.
أعوذ بالله من الشيطان الرجيم. يا أيها الذين آمنوا اتقوا الله ولتنظر نفس ما قدمت لغد واتقوا الله إن الله خبير بما تعملون. ولا تكونوا كالذين نسوا الله فأنساهم أنفسهم أولئك هم الفاسقون. لا يستوي أصحاب النار وأصحاب الجنة أصحاب الجنة هم الفائزون. لو أنزلنا هذا القرآن على جبل لرأيته خاشعا متصدعا من خشية الله. وتلك الأمثال نضربها للناس لعلهم يتفكرون. هو الله الذي لا إله إلا هو عالم الغيب والشهادة هو الرحمن الرحيم. هو الله الذي لا إله إلا هو الملك القدوس السلام المؤمن المهيمن العزيز الجبار المتكبر. سبحان الله عما يشركون. هو الله الخالق البارئ المصور له الأسماء الحسنى يسبح له ما في السماوات والأرض وهو العزيز الحكيم.
صدق الله العظيم. Now we start with the brief speech by Professor Shihab Al-Mashhadani.
بسم الله الرحمن الرحيم، والصلاة والسلام على رسوله وعلى آله وأصحابه ومن دعا بدعوته إلى يوم الدين. وبعد، أيها الإخوة الكرام، أيها الأخوات الكريمات، أنا الحقيقة أشكركم على مجيئكم. After all, you work very hard during the week. You need to rest on Friday and Saturday. So this is a sacrifice from you to come and attend this conference, the speakers and the audience. I don't want to take long time. The idea of establishing this came from the resident of King Saud Fellowship, who came to me and they said that we want some conference about diagnostic hematology. So I welcome the idea. They did all the effort. I did very little. Most of the effort is done by the organizing committee. which you know their names are listed on the sheet which you have, and they went to everybody and take his participation, agreement for participation. And so I hope the audience will be more than that, than what we have now, but we'll wait. I think it's too early now. Really, this symposium is the first, and I hope it will continue for the next many years, inshallah, as it will give a broad spectrum to diagnostic hematology. As you know, each subject needs 1 day. If somebody is going to talk about leukemia, for example, he needs 1 day. Or bleeding disorder, he needs 1 day. Thrombosis, 1 day, and so on. So it's a very big subject, but inshallah you will benefit from it, coincide, and we concentrate mainly on the laboratory aspect of this. I don't want to take long time from you, but it's my pleasure to welcome Dr. Tariq Aweda for his first speech about thrombosis. Dr. Aweda.
Assalamu alaikum. Good morning. It's my pleasure to be with you here and see you arranging this interesting course, which is the first in its kind. And I would like to congratulate the team led by Dr. Shihab and organized by Haytham and Maher, who succeeded to put all this together to bring you something I hope that will help you in your career in the diagnostic and clinical hematology. I've been asked to talk about thrombophilia, which is a big subject that it requires a whole day. So I tried in this subject to go through some very basic definitions, since we are talking about a review course. So I thought we will start with some agreements on terminologies, which is sometimes, especially in the area of thrombosis and hemostasis, have some confusion. I'll give you some backgrounds of the things we all know, just to highlight on these things, and that will take us to focus on the thrombosis from the clinical point of view as well as from the lab point of view. And I will explain some about the thrombophilia definition-wise and how to work it. I will end my talk by few slides about managements of thrombosis in different situations. So let's start with a case to make life more interesting, and then we can end by discussing the possibilities in management of this case. The case that I would like to present to you is a 77-year-old lady who's known case of pulmonary fibrosis on home treatment with oxygen. She had few weeks of shortness of breath and some chest pain with increased immobility in her house. She came more than once to the primary health care complaining of progressive shortness of breath and complaining of difficulty sleeping on one pillow. Presented to ER more than once. Finally, somebody wanted to investigate her, and she was diagnosed as BE for some time. Then they went and did leg ultrasound, and they found an old or DVT present there. Patient, as we all know, started treated with low molecular weight heparin, then followed up with a long-term prophylaxis. The question here, for an old lady who's immobile, who had two thrombotic areas, but all coincidentally diagnosed at the same time, what type of long-term anticoagulation? I hope we can discuss this at the end of the talk. Let's go through some of the definitions. Let's agree on some of the definitions. We use a lot hemostasis, coagulation, thrombosis, but these words a bit of create a bit of confusion sometimes. The hemostasis, word-wise, it refers to stop bleeding, and because of that, in the Hematology Society and in the blood disorder societies, this has been referred mainly to clotting factors or bleeding related defects. And you know all that it's a process where the blood clot get formed through different mechanisms that we will highlight. The coagulation, if we take that word in medicine, the clotting of blood. It's another terminology. And it involves the process by which the blood clot to form solid masses or a clot. Thrombosis, on the other side, is the formation of blood clot inside blood vessels. So you can see all these words refer to almost the same thing. And I'll give you what people agreed on in the International Society of Thrombosis and Hemostasis, what to call. Other three terminologies we need to know about them is the procoagulants, which are proteins that promote the coagulation of the blood, and the anticoagulants, which are the opposite to the procoagulants. It's a protein that formation or prevent the formation of blood clot. Fibrinolysis, it's a system. It's a mechanism by itself to remove this clot after formation as a consequence of hemostasis or clot formation. The thrombosis, which we described as formation of clot, it could be arterial and manifest as myocardial infarction, stroke, or peripheral vascular disease, or it could be venous and can manifest mainly as DVT, BE, or post-thrombotic syndrome. If we go and take the thrombophilia and try to dissect the thrombophilia, we will end by having two types of causes for thrombosis, which are hereditary or acquired. And thrombophilia will describe venous thromboembolism, thrombophilia will describe arterial thrombosis, and thrombophilia also will describe pregnancy complication. If we take all these 3 or 4 terminologies and try to put it together, we will end by having a balance between the clot and bleeding, where the hemostasis works in one side and the others work on the other side. But all of them, they work together to maintain the fluidity of the blood in the blood, be it small vessels or large vessels. Few words about the phases of hemostasis. Again, it's something we need to know because it's important when we dissect the thrombosis and work up on the thrombophilia. We know that the hemostasis can be primary hemostasis, which refer to as a white clot, and that primary hemostasis, which usually involve the endothelium, the platelets, and some of the coagulation factors. They are the first step to maintain the hemostasis and prevent bleeding by the interaction of these elements, mainly the endothelium, and the collagen, the von and the platelets, and they form a small clot by adhesion, aggregation, secretion, and procoagulant activation of the procoagulants. This small thread of platelets, which is very mobile, can move quickly with the shear stress of the blood vessels, unless the second phase, which is the secondary hemostasis, start, where that small platelet clumps or platelet aggregation will be strengthened by the formation of the fibrin thread through the coagulation cascades that will stabilize the clot and prevent the formation or the movement of the clot by shear stress of the blood within the blood vessels. It's due to sequential activation of zymogens, and it's called red because it interrupts within that network red blood cells and white blood cells. After formation of the clot in the primary and secondary hemostasis, we need to have a mechanism to stop that. Otherwise, it will continue to form, and that continuation of formation of the clot will result to not only to repair the trauma or the injury to the blood vessels, but it will result in the blockage of the blood vessels, and that what happens if we have a defects in the clot elimination or the fibrinolysis system. The endothelial cells are very rich when it comes to the coagulation and the involvement in the both the formation and prevention of the flood formation. It's a very complex system. I will not go through it, but remember that endothelium is a key in the hemostasis, be it in the early phases or in the late phases, and in the prevention through the anticoagulants activity. The cascade of the coagulation system, which we all know for many years, since started around 50 years ago, it involved two ways, the extrinsic pathway and intrinsic pathway, and we all know that it has three phases. The two extrinsic and intrinsic will end by the common pathway, and the common pathway has its two major components, the tinase and prothrombinase phases. This just highlight that the common pathway, which is the site where the final action of the thrombin formation and formation of the clot that will stop the bleeding will occur here, and as well as the polymerization and the stabilization of the clot. I need you to know one thing, and that's coming in the near future, is thrombin is the king of the whole story. Thrombin is the main player in this when it comes to clot formation. And as you can see that thrombin has an effect on the promotion of both the procoagulant site as well as the anticoagulant sites. And the percentage or the amount of secretion of thrombin can, or it's the thing behind activation of the anticoagulation as well as the activation of the cascades, and it will be involved in the propagation of more thrombin formation. That's why now or in the last 10 years or so, the thrombin generation measurements by different methods became a kind of a focus in research to study the clinical as well as the diagnostic tools for prediction of the clinical features of some of the bleeding disorders as well as clotting disorders. We cannot pass without highlighting the cell-based module, and it's a new concept, relatively new concept of explaining the coagulation cascade or the formation of the clot. But this time it's different from the traditional, the old method, the one that everybody knows, that it's start by extrinsic and intrinsic pathway. No, this concept is based on that the whole coagulation occurs on the cell surface, on the cell, the surface of particular type of cells, and that due to identification of the membranes or tissue factor that is expressed on the membranes of these types of cells. Mainly, if we can say, platelets is the surface that most of the coagulation occurs, but remember that tissue factors also being expressed by endothelial cells, so the coagulation can occur on the endothelial cells. Monocytes express tissue factors, so activated monocytes can have or can play a role in the formation of the clot, as well as the tumor cells. And if when we talk about the cancer-related thrombosis, for example, one of the mechanisms behind cancer-related can be explained by the cell base, because we know sometimes, particularly types of cancers like prostate cancers, for example, they are rich of tissue factors. So in cases of prostate cancer and other cancers where the percentage of thrombosis can reach up to 20-25% during the course of this is one of the explanation of the mechanism behind it. The cell-based module can be divided to 3 phases: initiation, amplification, and finally thrombin action, which is again take us to the king of the whole process, which is the thrombin. And as you can see, it occurs on the cell surface. It involves the same zymogen, the same factors, but here the interaction is a bit different. But at the end, it's activation of the cascade of the coagulation that end by formation of the clot. And as you can see, again, the thrombin plays a major role here. Before we enter to the thrombophilia, we need to again remember very old concept, but still up to date. It's one of the very well accepted concepts. It's been suggested by Professor Virchow long time in 1800s. And he wanted to explain the causes of clot formation in the vein. And he came up with a triangle of 3 factors, 3 major factors that are involved in the formation of the clot. That would include the endothelium, and that's interesting that since that time he realized that the endothelium is an important element in the clot formation, hypercoagulable state, and circulatory stasis. And with our new information that offer the 100 of year or so we gather, now we agree with Professor Virchow that yes, the endothelium had get involved a lot, and we see this with patients with indwelling catheters, or patients where a procedure, or patient post cardiac cast implementation of stents in the cardiac vessels. These patients get more prone to thrombosis. Patients with valvular damage get more prone to thrombosis. The hypercoagulable state, which now we know more about them, and we will talk more about the different type of hypercoagulable state, or the thrombophilia. And definitely the circulatory stasis being confirmed. We know that patients with immobility, like our patient, are at a high risk of having thrombosis. So this concept, which is from 1800, is still valid up to date, and we have to recognize and keep it in our mind. Finally, before we go to the more clinical, the fibrinolysis. The fibrinolysis system is an important system, and many times we forget that there is a system of fibrinolysis. We test for various clotting factors, we test for the anticoagulants, but we forget that there is a system that is needed to prevent the propagation and the continuation of the clot formation, and that system is the fibrinolytic pathway. The purpose of this system is to remove the clot or thrombus from the injured sites. After the journey, after complete healing of the injury, the clot is not anymore needed. It needs to be removed. How to be removed is by the fibrinolysis system, where the plasmine here is the product of that pathway and is a crucial in the activity. Again, because of the time, I will not go in detail, but we have to remember that there are factors that been activated by the plasmine, which is tissue plasminogen activator, urokinase activators, or plasminogen activator inhibitor. The end results of this fibrinolysis is the D-dimer and the fibrin degradation products. And again, this D-dimer and fibrin degradation products are important parameters, are important tools. And you see in the last few years, the D-dimer had gained a lot of concerns, especially when it comes to the rule out of the thrombosis formation in patients with suspicion of thrombosis. D-dimer by itself, it's a talk by itself. It needs a lot of explanation, but the message I need you to take is D-dimer is an important test, and we need to know the value of the D-dimer as well as the limitation of the D-dimer. D-dimer is a good when it's negative. Its negative predictive value, it reach 98%. But when it's positive, it can be positive due to thrombosis, but there are other conditions where the D-dimer can be positive. One of them is our patient, the old age. In old age, D-dimer being found to be high even in absence of actual thrombus formation. Other situation, pregnancies, cancer, or different situation where the D-dimer can be positive. So we cannot take of guarantee if the D-dimer is positive, but definitely if the D-dimer is negative, we have a very high probability that the patient doesn't have thrombosis. And as any mechanism needs an antidote to stop that, because fibrinolysis, if it get continued to be activated, that will result even in dissociation of the clot that is already been done. So this mechanism has to have a stop mechanism, which is the antifibrinolytic system, where the thrombin activatable fibrinolysis inhibitor circulate in the plasma, raise to a level to stop this process. Again, I will not go in detail about this one, but we need to know that this system, again, has to be active, and in some situation where the patient may present with bleeding, both thrombosis can be due to defect in the tissue factor pathway inhibitor or thrombin pathway inhibitor. Let's go now to more clinical, explain the thrombosis in more clinical scenarios. What is the VTE? VTE result from the presence of thrombus that may occlude some of the blood vessels and prevent blood supply to that tissue. As we mentioned earlier, can manifest mainly as deep vein thrombosis if it occurs in deep veins, or it can manifest as pulmonary embolism if it occurs in the main pulmonary vessels, and it is a serious clinical situation if it's not detected early, and if it is in a major, especially if it is in a major organ, it can lead to death. If we talk about the epidemiology about the VTE, VTE is very common condition with an estimated death worldwide yearly more than 500,000 deaths. It's quite high. And it's been estimated that more than 300,000 VTE related deaths in US by itself, and in VTE estimated to cause at least 3 million deaths worldwide, and in Europe, it's more than 500, and worldwide more than 3 million. the VTE can be silent or can be evident. The diagnosis of DVT by itself, as again, these are some of the figures from mainly United States, 800,000 patients per year. It's a good amount of patients diagnosed only with the DVT. The fatal BE can be seen in 50,000 to 200 patients per year. Non-fatal can be around 150,000 per year. And another important thing, and I will highlight it a little bit, which is the post-thrombotic syndrome. We diagnose the patient, we start the treatment, but we forget that one of the complications that happens post DVT is the post-thrombotic syndrome, which can be seen in up to 500,000 patients with different stages, different clinical severity of this syndrome. The question that usually is being asked, that the VTE, is it a disease by itself or a manifestation of a disease? As I alluded earlier, that from early days, from 1700th century, physician had reported the association of the DVT with an underlying disease. Some of these underlying conditions, like the immobility, it's been reported long time. Other, like the cancer, which been reported by Professor Bernard in late 1800, by Virchow's late 1800 as a major pathology of the hypercoagulability. Professor Arnold Trousseau was the first to report the association between cancer and thrombosis, and the concept is emerging that most, if not all, cases of VTE represent an underlying genetic predisposition, but with or without an acquired precipitating events. The concept of an underlying genetic defects, it's an old concept, but being consolidated with more epidemiological studies about different type of already recognized genetic defects. We will go through them a bit quickly, but let's describe more in detail about the clinical presentations of the thrombosis. If we take the DVT and see the severity of the DVT, the different presentation of the DVT, we know all that DVT can present either distal or proximal. The distal, when we refer to distal DVT, and that's important when we make decision for anticoagulation and the time for anticoagulation. If the distal DVT, we refer to the things happens or the thrombus happen below the knee, while the proximal one, anything happens above the knee and can be extended up to the pelvis. Usually it begins distally, but sometimes it's the opposite, proximally. DVT symptoms and signs are very non-specific. The patients can present with swelling, tenderness, and some pain, but it's not really specific. Inflammation of the blood vessels can present with that situation. So here, if a patient presented with you with some symptoms suggested, you need to put in mind the DVT, because cases of DVT had been missed with confusion of cellulitis, confusion with edema. Pulmonary embolism, on the other side, occurs when part of the thrombus, usually the thrombus that formed in the DVT in the leg or in vessels, in veins, pass into the pulmonary circulation and block the main artery of the lung and prevent oxygenation of that part to the lung. May lead to increased pulmonary vascular resistance, and it impaired the gas exchange, ventilation, perfusion, value. It increases the pressure on the right heart and can cause dilatation and dysfunction, and that lead to ischemia of the right ventricular wall. And that's why one of the things that we look at when we examine these patients, look at the right ventricular functions. When it comes to the symptoms of the BE, it's more specific than the symptoms of the DVT. Patients present with shortness of breath, although that can be sometimes being missed or underdiagnosed, especially in patients with an underlying lung conditions, like in our patients, where the BE had been missed more than once because the patient has a pulmonary fibrosis, and shortness of breath had been related to the pulmonary fibrosis, but still, it's the intensity of the shortness of breath when it comes to pulmonary embolism is higher than that seen in other conditions. Chest pain, tachypnea, tachycardia, anxiety, hemoptysis, and fever, all seen with pulmonary embolism. How we do diagnose these conditions? As I mentioned, the clinical symptoms and signs are unreliable, especially when it comes to DVT. That's why physicians who are dealing with the thrombotic patients over years realize that we need to have a standardized tools to diagnose these cases. So they came up with what they call it clinical probability scoring system. And there are different clinical probability scoring systems available in the literature. The most well accepted and well validated is the Wells clinical probability, where it's been constructed early or late in 1997 and been validated extensively in the different areas, including in our area. It's been validated, and it's a nice tool, especially if you combine that nice tool with a D-dimer. And many studies had shown that a negative D-dimer, when it's combined with a low probability, you have about 98% of a negative predictive value, which is excellent tool. But still, the positive predictive value is more relied on the preclinical scoring system rather than the D-dimer, as I mentioned earlier. So clinically, you have a suspicion, you can rule out some of the patient, but definitely you will have some or many patients that require more investigation. What to do for them? If the patient presented with sign, symptom, suggestion of DVT, you will go for compression ultrasonography, and compression ultrasonography by itself, it has its limitation because it's an operator dependent. It depends on the experience of the person who's performing, the radiologist who's performing the ultrasound. And on many studies, it shows variability between 70 to 90% difference in the operators. So the positive predictive value of this test can be up to 80%, if you can say. So still there are around 20% can be missed by the ultrasound. That's why it's been recommended even by the ISTH and other society, ACCB, that if you have a suspicious cases and you did it once, you don't stop there. You do serial ultrasound measurements. You may detect the patients if there is a progression in the thrombus, or it become more evident by another operator. When it comes to the BE, we have three different radiological methods. The CT pulmonary angiography, the CT spiral pulmonary multi-detector CT, and the FEQ scan. The FEQ scan used to be the gold standard, where you see the perfusion exchange, and it's been minimized now with the use of multi-detector CT, where even subsegmental small BE can be detected by this. So rarely we use now FQ scan, and we keep it for those difficult cases where the clinical scenario is suggestive of BE, but the spiral CT or the multi-detector CT did not prove it. The phenogram is again another method that can be used for detection of the thrombus in the deep veins. It's been used, but it has its own risk. The dye and the post-phenograph, some patients may form ulcers in the site of injection, so it's less ordered in the last few years. We will move now with the last 20 minutes or so about testing for thrombophilia. That's an area of debate, and traditionally the testing for thrombophilia was considered as a cornerstone for the management of these patients. In the recent few years, the debate increased, reaching to a level that some of the physicians, they don't like to test for the thrombophilia. Let's go through some of this debate, but we will start by numbering the causes of thrombophilia. As I mentioned earlier, we can divide the causes of thrombophilia to two major groups. The inherited prothrombotic mutations, where there is an inherited genetic mutation predispose the patient for thrombosis, and that can be factor V Leiden in its two forms, either heterozygotes or homozygotes. Prothrombin 20210, which mainly in the heterozygotes form, protein C, protein S, and antithrombin 3. These being considered for many years as the main hereditary causes for thrombophilia, with different prevalence, with different percentage of predisposing to the thrombophilia. On the other side, the acquired prothrombotic stimulus, and it's being called a stimulus because it's an additive stress condition that can add to the genetic, if there is a genetic, or can act by itself as a thrombophilic factor. Antiphospholipid comes as a first because it's a prevalence and its seriousness when it comes to the thrombotic manifestations, malignancies, immobilization, surgery, pregnancy, different estrogens components or oral contraceptive pills, hyperhemocystinemia, which can be either acquired due to B12 deficiency or to a lesser extent as a result of MHFR mutation, and finally heparin-induced thrombocytopenia. And the list is expanding. The list is long, but this is the most common causative agents when it comes to thrombophilia. If we look at the prevalence of the hereditary, take the hereditary risk factors and look at the prevalence of this hereditary risk factor in the VTE. Factor V Leiden, which being described in late 80s, early 90s in Leiden, Sweden, with a prevalence in Sweden reaching to 7% of the population, but worldwide getting some low prevalence like Chinese and Japanese, where it reached up to 0% in some communities and 7% in the high communities, the Caucasian, and around 4% in the Middle East and the Africa. The general preference is people agreed to be around 4%, and it's high. It's the largest prevalence when it comes to the genetic inherited factors. It can cause 20% of unselected VTE, and in familial VTE, it's 45% of those familial VTE. Those who are working in the field of thrombosis for a long time, can see the factor 5, especially for those who've been worked for factor 5 Leiden, can see that factor 5 Leiden run in the family. You can have family comes with 5 children. They have thrombosis. They have tendency for thrombosis, recurrent thrombosis, especially in the homozygotes form. Prothrombin comes as a second prevalent, most prevalent cause, which is representing 2%, and again the unselected, the sporadic VTE 6%, but in the familial 18%, and the protein C, protein S, and antithrombin represent very small number, but it's serious, and as you can see, it's 1% of the unselected, and when it comes to families, it's more higher. The influence of hereditary risk factor on probability of first VTE had been shown in many studies. If we take the general population, the relative risk of general population where there is unknown risk factor, if I can say, it's 1. But if you take the factor 5 Leiden, the relative risk of having DVT in the heterozygotes form is 5, and in the homozygotes form is 80%. So it's quite high, especially with the dose, increase the dose of the genetic of factor 5 Leiden. And you can see that the protein C and the antithrombin has, again, different relative risk factors. This relative risk factors is not important only to detect the prevalence in the community, in the families. It's important for us when we start managing these patients to see the probability of reoccurrence after the first DVT. If we take the temporary risk factors, which include the immobility, post-surgery, it's only 1. That's why we give 3 months and we stop. And some people, they even give 6 weeks and they stop, because the chance to reoccur is very low. Patients with factor 5 Leiden, as heterozygotes, they have double the risk. Patients with homozygotes, they have more, 4% risk factor. Patients with antiphospholipid is higher than the heterozygotes, and it carries a risk quite close to the homozygotes. But if you look at the last 3 items, which is the unprovoked DVT, which we don't know the reason. Maybe there is a reason behind that. That reason could be very thrombogenic, but we don't know it. And when they lumped all these, the unprovoked, they found that it has a higher, much higher risk factor, around 8. And patients who have a recurrent thrombosis, even if they don't, if they have or they don't have, with the recurrent thrombosis, they have higher risk factors of more recurrent, and definitely the active cancers. That's why the current treatment for active cancer is to extend the management of the thrombophilia or thrombosis related to cancer to 6 months, and there is an ongoing study to increase it to 1 year. The 6 months being approved by the clot trial, and now they are working on another trial to extend it, because it's quite thrombogenic, and some of the cancer, even there is an ongoing work to start the prophylaxis due to the use of some of the drugs or due to the thrombogenic nature of that cancer. What is the rationale from the thrombophilia testing? Why we test from thrombophilia? We test because we need to do few things. First, prophylactic anticoagulation during high-risk situation. If you test somebody and it came to be positive, even if they don't have a thrombosis, and they get exposed to a stressful situation, that stressful situation during pregnancy, immobilization, or surgery, they require a prophylaxis. So this is one of the indication for the testing. Those patients who develop the thrombosis, and we would like to make a decision about the duration of thrombosis, the testing for thrombophilia will help us to tailor the duration of this anticoagulation. If we diagnose a patient with antiphospholipid, that category of patients require extensive testing and identification, because as we had seen that they have a higher rate of or higher risk of recurrence. The presence of antithrombin deficiency sometimes help us to tailor the early management of the patients. Patients with antithrombin deficiency, they show an early heparin resistance because the antithrombin is needed for the heparin, especially for patients who will start with heparin infusion. So if we have a patient who have start to show some resistance, we give heparin at the dose that is being recommended, and still we can't see an anticoagulation effects. We have to think about the antithrombin deficiency and test for the antithrombin. We know that 2 or more allele or 2 or more risk factor increase the risk of recurrence, and that's evident with the presence of factor V Leiden in its homozygous form, evident in the presence of factor V Leiden and prothrombin 20210. And finally, we test if the family requires genetic counseling. The family, especially those families with high prevalence of thrombosis, when the family comes and the patient come and say, I have 5 brothers who have frequent thrombotic attacks, or they have recurrent, do I have a risk to have a thrombosis, especially if that person will go through a special situation like surgery, or she's getting to be pregnant. Sorry. What is the laboratory testing for thrombophilia? We have a big panel of laboratory testing. For factor V Leiden, we tested by 2 methods. We tested by functional method, the activated prothrombin resistance, which is a coagulation method. So we test the end result of the factor V Leiden mutation, or we test the genetic mutation by looking at that mutation present in its homozygous form or heterozygous form. It's the same for prothrombin. We test for the level of prothrombin by measuring the prothrombin activity, and we test for the genetic mutation by the molecular testing. When it comes to antiphospholipid, this is one of the area of difficulty, and I think all of you know that antiphospholipid, which is a group of heterogeneous antiphospholipids, antiphospholipid syndrome is caused by a group of heterogeneous antiphospholipids. These antiphospholipids, some of them we know, and many we don't know. And those we know, we need to test for them. And particularly the lupus anticoagulants, those antibodies that interfere with the coagulation and cause prolongation of coagulation tests. Adding to that, we need to test for the immunological ones, the anti-cardiolipin and the anti-beta-2 glycoprotein. Plasma level of homocysteine is being recommended as one of the things, especially if you have a suspicion. Some of the patients you will see presenting with high MCV and low anemia, and if you test B12 is low, homocysteine is high, and it could be the reason behind the DVT in these patients. Definitely the antithrombin, protein C and protein S needs to be tested, and there are some concerns when it comes to the testing of that. This is not the inclusive and exclusive list. This is the common test. There are other tests that can be mild, like other prothrombotic factors, or it can be measured like looking for the cancer in a patient who's presenting with thrombosis and you don't find a reason. Some people they can be very aggressive, and especially in old patients they go and screen for the cancer, looking for a cancer as a causative of the thrombophilia. When to test and what to test, that's a more important question when you face a patient with DVT or BE. Do you initiate the work before you start or after you start? In most of the clinical situation, the patient comes to the emergency or comes to an internal medicine, so they diagnose him, they start anticoagulation right away because this is a clinical situation that doesn't wait till you come and prescribe the tests. But if you have the chance to detect a patient who is presented early and you have a chance to order the test, it's preferred to initiate the workup before you start any managements, because we know that heparin affects the measurements of antithrombin 3, so it gives us a low antithrombin 3 level. It affects the lupus anticoagulants, it affects the factor Lisfet testing, and it's an inhibitor for molecular testing, so we will not be able to do the molecular testing on patients who are on heparin. If you delay the process of testing when you initiate the warfarin, again, the warfarin can affect some of these measurements. We know that the warfarin will reduce the protein C and protein S, and it affects the testing for lupus anticoagulants. There is an extensive guidelines for the thrombophilia patients with BT. That was the European guidelines, and I will not go in details, but basically, it summarized the actions that the physician need to take to diagnose or make the thrombophilic workup. In the last few minutes, I'll just quickly pass through the goals of the therapy. Why we treat the patients with thrombosis. What is the goal of the treatment? The goals that we put in mind when we start the treatment is to relieve the symptoms, because the patients have symptoms now. The symptoms, be it shortness of breath or severe pain in the leg, so we have to give something to relieve that pain. Prevent immobilization. The patients, especially those who present with DVT, they have a high risk to have this thrombus to dislodge, and in up to 20% of these patients, they have the concomitant BE present with a DVT. Prevent reoccurrence after we stop the process. So we don't want them to have another attack, and prevent the post-thrombotic syndrome. There are different types of anticoagulants, be it unfractionated, low molecular weight, or now we have the oral anticoagulants, the warfarin, or the new oral anticoagulants. The ACCP, which is the most acceptable guidelines for the management of DVT, and it's in its last format in 2012, the 9th edition in 2012, had put some recommendation in different situation, and it gives an advice to the physician what to use, when to use, for how long to use them, with different grading recommendation for that for these patients. For the oral anticoagulants, we all know the warfarin and its side effects, low onset, low offset, and that bring us to the new area, which is looking for the ideal anticoagulants. And again, there are requirements for the ideal anticoagulants to be oral, no specific food or drug interaction, no routine anticoagulation monitoring, fixed dosing, and no high risk of thrombosis. The new anticoagulants that are available in the market, and you should know about them, they are two groups: either direct thrombin inhibitors or anti-10A inhibitor. And this group of the anti-10A inhibitor includes the already approved rivaroxaban for the management of DVT and as well as the prophylaxis. The apixaban and edoxaban is still in the early phases. On the direct thrombin, we have the dabigatran, which is approved and recently been approved also for DVT management. I will stop here, and I hope it was clear for you.
Thank you, Dr. Tariq.
Question now?
Yeah. If there is any question.
Thank you, Dr. Tariq, for this wonderful presentation. One problem that is facing us, especially in the anticoagulant clinic, when the patient is having 1 or 2 risk factor for thrombosis. He's diagnosed for PE, for example, or DVT, and this is, for example, during, for example, a female with long journey and anticoagulant or oral contraceptive pills. Do I need, after the treatment, to do the thrombophilia screen, the inherited one?
That's the area of debate. If you would like to go few years back, most of the people, they would go and do thrombophilia risk factors. The trend now is to tailor the thrombophilia risk factor if you have other risk factors. Like if this lady who's with oral contraceptive pills came and in the history she said that I have a brother or a relative who have a thrombosis. This is an indication to do a thrombophilia, especially start with the genetic thrombophilia workup. But if the patient have no family history, it's most of the people, they don't go now to test for everything. They will stop and ask her to stop the oral contraceptive pills and prevent her from using it, but they don't go and do investigation. I can tell you one story when the factor V lied in 1992 came as one of the famous ones. A famous study in US came to look for or screen normal population for the factor V lied, and especially the ladies became very worried about the oral contraceptive pills. And the recommendation from that study, because they found people who are in the community who have who have factor V Leiden mutation, but do we need to prevent them from oral contraceptive pills or screen the community to prevent them from using the oral contraceptive? That's impractical, and it was not clinically significant, or the results was not statistically significant to conclude that patients with oral contraceptive pills who develop thrombosis, we need to test for them. So in summary, it's again, still there is no clear guidelines. The guidelines, I can give it to you, the guidelines of the European suggest, but they don't recommend to use it, to test it.
No more question?
Amun.
Thank you, Dr. Tariq. Just my question, why heparin should prevent us or impede us from testing for molecular testing, like for factor V Leiden or prothrombin gene mutation, if the patient is on heparin? What's the relation? Why we cannot test for factor V Leiden if the patient is on heparin? This is molecular testing, my understanding, gene related.
Because the heparin, now if you collect blood in heparin tube and you send it to the molecular lab, they will reject it. Why? Because the heparin act as an inhibitor for PCR reaction. So that's the reason why we don't test patients while they are on heparin.
Thank you, Dr. Tariq. First question, is it, we can say generally that is, every patient with provoked DVT, no need to do for him thrombophilia secrete?
Again, this is an area of debate. Nobody would prevent you of going and doing testing. But the trend now, I can tell you those who are working in the field for many years, taking the example as the McMaster Institute, which is the Institute of Coagulation in Canada, they start stopping this practice. But they didn't come up with a solid recommendation, no need to do it, because still we don't have an evidence base to prevent you as a clinician, prevent you as a physician to test for these patients. But if you ask me, if a patient with a clear thrombophilia risk, a clear provoking factor, he is having this thrombosis post-surgery, he's young, there is no family history, I wouldn't do it.
But sometimes we afraid, sometimes we can judge like this. This patient has simple trauma and then he get the thrombosis. Many other patients who get trauma, they will not get any thrombosis. So we start to doubt. Practically, we are preventing ourselves and we are doing.
That's why we could not reach to a conclusion. This is one of the debate area, why some people, if you give oral contraceptive pills to 100 patients, not all of the 100 women, not of them will form thrombus, but particularly some of them, they have a predisposition to form that. That predisposition, is it genetic or not genetic? That's the reason. There is a nice paper in ISTH addressing this point, and it talks from the statistical point of view. And the conclusion of that paper, which is in 2013, that the genetic factor, you have to look in when you test for the coagulation, you look to bivariant analysis, not univariant analysis. And he nicely elaborated on the genetic predisposition with the acquired predisposition. And clearly he identified that many of the genetic, we don't know about them. Maybe these patients, they have different genetics. Not all of the causes of thrombosis is only due to factor V Leiden or prothrombin or recently the JAK2 mutation. We are gaining information, but really, does it make a difference when you test for them, when you make a decision for long-term anticoagulation? That's the main reason behind. Let's hold the horse if they have only one attack and there is no family history.
Thank you, Dr. Tariq.